our health and quality of life. Okay, so let's also have time for, let's just do 2 paper summaries. So let's see, then the italicized ones we've already talked about. Okay, so let's see, so this paper is going to be presented at CHI in about a month. So online grocery delivery services, an opportunity to address food disparities in transportation scarce areas, and this is with Tawana. So we conducted a pilot experiment with 20 participants consisting of a randomly assigned group's 1-month use of an online grocery delivery service and a control group's 1-month collection of grocery receipts, and a set of semi-structured interviews. We found that online grocery delivery services, A, serve as feasible model to healthy food access if they're affordable and amenable to multiple payment forms, and B, could lead to healthier selections. And if is this the best paper?
Yes.
Okay, yeah, so this was also, this paper also won a Best Paper Award, which means that it was judged to be among the top 1% of all accepted papers. Yeah, and that's quite an accomplishment. And I think it's one of 3 for the department, which is also quite a collective accomplishment. So, let's see. Okay, then we have one from Naz. So, what happens after disclosing stigmatized experiences on identified social media, individual, diasporic, and social network outcomes? So this was with Naz, disclosing stigmatized experiences or identity facets on identified social media, for example, Facebook, can be risky, inhibited yet beneficial for disclosure. I investigate such disclosures as outcomes when they do happen on identified social media as perceived by the individuals who perform them. I have drawn interviews with women who have experienced pregnancy loss and are social media users in the US. I document in detail outcomes at the social/network, individual, and dyad levels, and discuss theoretical and design implications. So this was an honorable mention, which again, quite another great accomplishment. That means there's judged to be among the top 5% of papers. Naz or Tawana, do you want to, I don't know, anything else about any of these papers?
No, thanks for raising visibility of the paper.
No, thanks for adding them. Yeah, it always helps. I know that we have some papers that aren't on here yet, but again, if you just go to this URL, add in a short description of the paper. Again, it doesn't have to be CHI or CSCW, it can be anything that will kind of update all of us about what you're working on. Okay, any other announcements? Okay, so let me switch over to Rediet.
All right.
Great, so our speaker today is Rediet Abebe. So she is a PhD candidate at Cornell University in computer science. She's advised by John Kleinberg. She earned her undergraduate degree at Harvard University, where she's also going to be joining the Harvard Society of Fellows in the fall. So her research applies algorithms and AI to improve social good, and she's also co-founded Black in AI and the Mechanism Design for Social Good initiative. She's also going to be on the advisory committee to the directory working on the director working on the group for AI in the National Institute of Health. I probably make
that's
a little bit, but
good.
yeah. So everyone, please welcome our speaker.
Yeah, thank you. All right. Hi, everyone. everyone. It's really great to be here. I'm being taken a picture of. It's really wonderful to be here. I have been following a lot of the work that's been coming out of the iSchool here and haven't had the opportunity to meet many of you in person. And so it's really awesome to just be here and have these one-on-one meetings and also share some work that I'm very excited about with you. So we're going to keep the presentation slightly less formal. And so if at any point you have thoughts, questions, comments, just feel free to raise your hand, just mention anything. So that's how we'll try to do this. So as Steve mentioned, I kind of think about the combination of the set of techniques that we have in the sort of the econ CS community, but also applications of AI to social good, and specifically to improving access to opportunity, whether it's in the form of resources, information, or anything like that for underserved and marginalized communities. So that's kind of the overarching theme of my work. And today I'm going to talk about some powerful applications of data-driven and text-based data-driven, text-based data analysis-driven work in public health. And this is work that I started at Microsoft Research New York City in 2017, but it kind of was an ongoing work that was just recently actually accepted to ICWSM, so I'm very excited about seeing that to completion in some form. And this work has been like, it's informed a lot of my thinking about how to serve underserved communities in sort of data-driven context. So we'll try to have a discussion about that towards the end as well. So as many people here know, and as you all know, and maybe people who've been working in health know, especially data-driven policies are very deeply embedded in various health contexts. And having sort of high quality, easily accessible data and comprehensive data can be very useful in designing policies and evaluating and measurement and all these things that we really need to be able to do. And so if you're, if you're based in the U.S., this image that you have here of you're like in a hospital or a clinic and everything is being measured and there's a lot of data being collected is very familiar to you. But that's not the only way that we're collecting data that can be useful in health. There's also wearable devices, there's social media, there's all sorts of things that can be a source of a lot of rich and maybe even high quality data that we can use for health. And this data is used in a variety of ways. So one thing is just like getting a better sense of potential patients that can come through our hospitals, right? So you have electronic health records that try to merge a lot of data, try to get a holistic view of individuals. There's flu trends, right? We could try to use social media data or some other data that we might collect from hospitals to try to identify epidemics before they happen, or try to be as responsive as we can. And then at an even higher level, organizations like the NIH use data to decide how resources are going to be allocated, right? They decide, what's the sort of the composition of burden of specific diseases and what diseases are being maybe underfunded or overfunded or whatever, and try to allocate resources using this kind of data. But this data deluge does not apply to everyone. There are missing communities on whom we don't have a lot of data, and so we have very limited understanding of their experiences. And the ones that are missing are sort of the obvious candidates, right? Or communities that are already disadvantaged and marginalized and underserved are also missing in a lot of these data sources. So just to highlight 3 examples, obviously these are just a sample. There's many other communities that are also missing. But we know that mothers, and especially Black and Latina mothers, are dying at disproportionately high rates. But there's not a lot of quality data about their experiences in the healthcare systems, and so there's not a complete understanding of why it is that they're disproportionately experiencing these disparities in mortality during birth. We also know that autism is underdiagnosed among Hispanic communities. Again, we have some conjectures about why this is happening, but we know that there are missing children that we should know have autism or are on the spectrum, but we just don't know how to identify them because they're not enough data is present on those communities. Again, we also know that trans communities are missing, and in fact, it was only in the last couple of years that there was data collected specifically on trans communities to try to identify ways in which our healthcare systems are not completely serving the needs of this entire giant community of individuals. And an even striking example is maybe the gap that exists between developing and developed nations. So if you have spent any time in developing nations or you are from a developing nation, you know that this image that you see here of the clinic on the left-hand side, that's sort of, you have like these beds back to back, and some health like nurses or health experts that are occupying maybe every other bed or something. That's not very far away from the reality. If you walk around in Addis Ababa, which is where I'm from, there are some great hospitals, but there's only really a few of them, and a lot of clinics really do look like this, right? And if you think about information collection, this image that you have on the right-hand side of someone, going in with like sort of a notepad or something and manually collecting, surveys of an individual in like a village or whatever, a neighborhood, village, or whatever, is not also very far away from the truth. We know that that's how we collect a lot of data. It may or may not get digitized, or may or may not get digitized accurately. There may or may not be errors. You may or may not be able to access the data. That's just what you're working with, and that's a huge problem, right? Because we know that we don't have a lot of data, and even when we have the data, it can contain a lot of errors. So for instance, if you're thinking about death certificates, which are used for making a lot of really big funding decisions, if you're looking at, say, just South Africa, it's known that about half of death certificates contain a serious error. So just to see an example, the way that this death certificate was supposed to be filled out is at the top, you're supposed to say like the cause of death for the individual. And then after that, you're supposed to include every condition that may have led to that cause, but you're supposed to include it in decreasing, in sort of in chronological order, right? So it should say, 1 hour, 1 year, 14 years, and then the line after that should be something greater than 14 years. But it says 24 hours. And so if you're someone who gets this piece of paper, which has somehow magically gotten digitized, you still don't know what this person died of. And so you're just gonna have to decide whether this last bit was like, it was supposed to be 24 years and maybe they wrote 24 hours, or they wrote it on the wrong line, or you just don't know, right? And that's an issue because if you are a policymaker, at some point you may have to decide between what's causing more death. Is it the first line or the last line? You have to make this decision. And that makes it sort of very difficult. And death certificates are sort of like one of two things that you ought to have, right? You need to have birth certificates and you need to have death certificates. We know that every individual needs one of these. And even that is not reliably collected, let alone anything else that might happen in between. And this is like, before we started this project, I spent like a lot of time just reading these reports from the WHO and the African Union, just like trying to understand what it is that they're thinking about and how bad of a problem they think this is. And this one quote that that stood out to me said, unless gaps are identified early and accurately, simply providing a raft of general interventions will not meet the real health needs for the people of the region. So what they're saying is that not only are you in a situation where you don't have a lot of data, and so you may have to do like generalized interventions, you're also in a situation where you don't have the ability to do a lot of generalized interventions. You have limited resources, and so you need to identify spaces where those resources can be most effectively used and try to proceed in that way. But you have this sort of double disadvantage in that you have lack of data and sort of limited resources. So, we've been talking about health more generally, but let's focus in on one thing. Let's focus on people's health information needs. What information are people seeking, and how are those needs being met? Why does that matter? Well, if you're looking at HIV/AIDS, which is going to be what I'll talk about for the majority of this presentation, we know that people's knowledge about how HIV is transmitted and how it's not transmitted has a lot of consequences. It can lead to higher transmission rates than we would like. It can lead to stigmatization if you have individuals thinking that shaking hands is going to transmit HIV. That leads to further stigmatization. So we know that matters a lot. We know that for HIV-infected individuals, their knowledge about what can strengthen or not strengthen their immune system is also useful. It is it's a useful body of knowledge that can be used for managing the disease and leading healthy lives. We know that it matters when people get tested, how early they get tested. We know that these are things that matter. And so information can be very useful in managing the burden of the disease in the community that you're looking at. So that's why we want to focus in on people's health information needs. And what has previous work done in this general space? Well, the big sort of data sources that you have are these sort of top-down approaches where the Global Burden of Disease Study or the African Health Observatory, which are like both very big projects that you can look up, take data that's already available from the government or whatever at various places. They try to compile it as best as they can and try to have trends that say, like, what does the burden of non-communicable diseases look like? And then you kind of just like map that by year or whatever. But it's not very detailed data. This is very aggregated data based off of whatever you already had access to. And then we know a key set of sort of contributions that have been useful in this space are studies that use manual surveys that focus on very specific populations. So it can be people with disabilities who are HIV positive, or it can be couples who are both HIV positive, or something like this in like a specific country or even a specific city. You can go in, you can survey those individuals and try to get a sense of the specific health information needs of those communities. And these studies have been extremely valuable, but they have a lot of the sort of the limitations that can make it difficult to translate that into broader policy changes, right? You have to do it. It's not very scalable, right? You really have to like be aware of the limitations that come with surveying maybe only a couple hundred rather than like a lot of individuals, right? And so there's not really that much in between. So you have a lot of studies that do these surveys. You have these like top-down approaches that aggregate data and say the burden of HIV in Ethiopia in 2010 was this, right? And that's it, and not really that much in between. If you're looking at, let's say, infectious diseases in African nations, for instance. So it was sort of with that in the background that I arrived at this internship, and we thought about, how can we use maybe data sources that haven't been used in the space before to understand communities' health information needs. And the hope is that by using this, we can use it for potentially targeted education programs and programming efforts that we know that a lot of health organizations are doing in African nations. And we specifically wanted to use search data because we had this understanding that internet penetration is growing very rapidly in the region. Right now, it's covering about a third of individuals in African nations have access to internet. It might not be very active access, but they have some access to internet. And so what that means is that, and that's gone up actually significantly over the past like 5 years and 10 years. And so what that means is that you have a lot of individuals that were not previously online that are now just coming online. So this is like a sort of the first opportunity that you might have to try to understand what unique health information needs that they might have. It is scalable, it's real time, and it's relatively cheap if you're one of these companies already. And that's been leveraged to demonstrate efficacy in disease surveillance in a lot of other diseases and other continents. So I'm focusing on the 54 nations in Africa, but there's been a lot of studies in other parts of the world that have used search data for flu epidemics, for dengue fever, norovirus, and all sorts of diseases. And there's been a lot of interesting work there. And we know that with search data, it kind of gives us this ability to do like a bottom-up approach, right? Like we have this top-down approach where we can say, we care about HIV prevalence rates in these countries, and we're going to try to like get at that information as best as we can, or whatever. Or you can have a bottom-up approach, or in addition, actually, I should say, you can have a bottom-up approach that says, I have this sort of paper trail of information that you've left behind in using search engines, in using social media, and whatever it is that you're using, and I can get that to kind of inform new questions that I may not have asked before, right? Asking what's the HIV prevalence rate is something that I've thought about before, but asking, how much misinformation is there like related to this specific thing? Maybe I wouldn't actually know, right? And so this kind of helps you complement that, right? These top-down approaches that already exist. But there are obvious ethical and non-ethical sort of other limitations that exist. So for the ethics part, I can talk about this more in detail later if you're interested, but there was obviously, a lot of training that I had to go through at Microsoft just to make sure that I wasn't de-anonymizing information unintentionally, just, all that stuff. A lot of my access was also limited just to ensure that, you didn't accidentally end up de-anonymizing people, because search data is super, super, super sensitive data, right? This is like, I knew this, but then I was like spending a lot of time just like looking at a lot of search data, and I was just like, wow, this is, you get a sense of people. You actually, when you see someone's like sequence of searches, you're like, I can map that to like a person, right? So this is something that is important to be aware of. And I mention it in part because we really did let that inform the kinds of questions that we were asking. There were questions that, that we ended up just not asking, not because it wasn't feasible, but because, it just didn't quite feel ethical. And so we were like, we'll just try to answer a different set of questions. And then there are obvious limitations, right? I mentioned that a lot of people are coming online. We don't exactly know who these people are. The data is de-anonymized, so we can't say we know it's exactly this individual from this specific neighborhood of this specific country. Like, we don't have that level of access. And so it's important to not over-extract conclusions from there. And then the other limitation, which is also important, is even if we have someone online that's actively using search engines, we don't know what other sources of information they have. We don't know what they talk to their friends about, what they read in books and newspapers and radio, or any of that, right? So these are sort of like complementary limitations that are very important to be aware of in whatever conclusions we were drawing from this. So with that in mind, we asked, how can we use search queries to shed light on health information needs related to HIV/AIDS in all 54 nations in Africa? And we also wanted to understand how this information needs were being met, and specifically how it was being met online, right? Because we couldn't really talk to people offline and say, hey, I know that you asked about this thing. Did you talk to your friend about it, right? Like, we couldn't do that. So we were limited to just the online use. And to give you a sense of the data, so this was all search queries from mobile or desktop that contain the words HIV or AIDS. And it happened during an 18-month period from January 2016 to June 2017. And the data contained the raw search query, so it could say something like swollen lymph node HIV, and it would contain the country from which it was issued. Let's say it says Ghana. It would contain the date, and then it would also contain a traffic count, so you could have something like, here's a raw search query from Ghana on February 2nd, and 20 people asked this on that day, right? So you'd have a sort of count like that. In some cases, we also had anonymous IDs attached to each of it, and using that, we were able to look at patterns by gender and age groups, which I won't present on, but it's part of the paper if you're curious. And it covered all 54 nations in Africa. And one thing that was striking to me when we were doing this was that I could not find any papers that were using large web-based data to cover like more than 4 countries in Africa at a time, right? Honestly, even just like covering one country was very rare to come by. And part of the reason why I wanted to do this project was also to just garner more interest in issues that influence Africa, that influence individuals who are based in Africa, right? So I hope that people feel more excited to do more work in this continent, but also just collaborate with individuals that are based there. And if this is something that you're interested in, please talk to me. I'm here all day, right? So with that in mind, first thing we did was we just mapped the percentage of queries that contain HIV or AIDS, right? So what percentage of queries coming from like Botswana contain the word HIV or AIDS. So we had this percentage, we had this heat map based off of the percentages. And that looks a lot like the HIV prevalence rate, right? You have a lot of the southern countries in Africa having a high HIV prevalence rate, but also having a higher percentage of queries that contain the word HIV or AIDS. And in fact, this has a Spearman correlation rate of 0.7. And this isn't meant to say, we should now use search queries to predict HIV prevalence rate. We should absolutely not do that for a variety of reasons that I won't get into. But it is to say that maybe the offline experiences here are mapping online search queries, right? So this was indication that the data might be picking up something that mirrors HIV experiences of individuals in these nations. And what we were really interested in was the searches themselves, right? What are people asking? And so to extract that, we used LDA, the dictionary allocations, where as input you have a set of documents. In this case, each document is just an individual search query. And then as output, you can think of the output as sort of a cluster of words that are semantically linked, right? So these are going to be like themes that are emerging in these set of documents, where the set of documents use the set of searches. And you get to set how many topics that you want to have as an output, and we set it to be 100 topics. And this was after we sort of tried like 10, 20, 50, like a wide variety. And for us, the interpretability of the topics was very key. So we gave it to health experts and said, what level of granularity was helpful to you, right? And so they said, okay, 50 was like a little too granular. When you get to 200, you have like a lot of topics splitting, and 100 seems about right. So that's sort of how we end up doing it. And what do these topics look like? Well, I'm going to show you a sample of 6, but there are many other topics that are also interesting. I just don't want to show you all 100 of them. But for the sample of 6, so there were things that showed up that were very, that I had expected a priori. So symptoms, right, like it had words like pain, limb swollen, node, throat, positive, back, like all these things. We expected to see that. And the number on the left-hand side of each word is measuring the frequency of the topic in the entire data set. So sort of the average would be 1, right, because we had 100 topics. So it looks like symptoms was a relatively more popular topic than some other topics. We had, antiretroviral drugs. That was also something that we expected to see, right, people searching about drugs. We have topics related to breastfeeding. We also had a topic related to pregnancy specifically. Again, these were things that I would have expected to see a priori. But then there were some topics that I was surprised to see, didn't expect. So there was one related to, actually there was 2 topics related to stigma and discrimination. So these were folks asking questions like, I'm HIV positive, can my boss fire me? Which is a question that people actually do genuinely have to ask in some countries due to the lack of protection that exists for HIV-infected individuals. And then there were topics related to natural cures. So it had words like black seed, herbs, moringa, just like any plant that you can think of, people think that it might cure HIV. So this was, and then actually, okay, this was like I wasn't that familiar with topic modeling before I did this project, and I was surprised to see that it knew that these natural cures, like natural or like herbs curing HIV, were related to people praying, right, or people, prophets curing AIDS and HIV, right. So this was. I was like, it works, this is magic, right? But, right, so this is like sort of natural cures and remedies that people were asking. And then there were also topics related to sort of gender inequality. These were folks thinking about things like how does marriage inequality lead to higher rates of HIV. And so I'm showing you these cluster of words, but we can actually dig into it and look at representative words, right? So if you're looking at natural cures, it has things like prophet, I'm blanking out the name, but like I presented this work to a group of students in Nigeria, and they were like, oh, we know who that person is, and they mentioned the name. So I was like, okay, I guess this is like a well-known name that people know. I didn't know. So these were like various, prophets and other people healing AIDS and healing HIV. And then there was also things like honeybee venom cures AIDS and stuff like that. And why am I showing you this? It's because, if you are, so we wanted to know that we were actually had some added value here, that we were doing something that, couldn't have been done without using search data or hasn't been done yet. And so we said, okay, what do people know about various natural cures? So we did, a broad lit review of, papers and blogs and anything that we could find that showed that someone is like thinking about, let's say, moringa seed cures HIV. Like have people been doing research on that? And there was some things that we were able to find, but then there were other things that we just couldn't find, right? Like honeybee venom cures AIDS, a thing that actually occurred a lot in our search data it doesn't occur in any of the papers that I have seen, right? And so the way that we're thinking about it is that, and we have actually started having some of these conversations, it's to say that if we had these like list of like natural cure like searches that are showing up, we can give it to a health expert and say, here are the sort of the prevalent ones that we've been able to find in this country. And that might be helpful, right? So now, rather than going in and asking someone, hey, what misconceptions about HIV do you have? You can say, hey, do you think that honeybee venom cures HIV? And that, they might be more honest with you than just saying, like, list all your misconceptions. And they're like, well, number 1. Right? And so this can be complementary with that sort of the top-down approach that I was mentioning earlier. So this is one avenue of work that we're looking at. But who's Naz? Is Naz here? I am very excited to meet with you. We can talk about stigma too. I didn't end up including much of it in the, but this is another thing that that I spent a lot of time thinking about, and so very excited to meet. Yes. Good. Okay. So this is a heads up that we're talking soon. Are you not?
Did you run this country?
So we did it, so the first, like when the input into LDA was just all 54 nations at once, but then we also ended up doing like variants by topic, So so good, thank you, yes. You've seen the slides before. more. But, right, so then, yeah, so what we wanted to do was now look at like topic popularity and how it varies by country. And also we wanted to know, are certain topics more associated with the HIV prevalence than others, right? That was also something that we were curious to ask. And specifically, I won't show you all 100 topics, I'll focus on the stigma topic, right? So do you expect to see variance in searches related to stigma by country? And then also, in countries where you see higher rates of searches related to stigma and discrimination, do you expect to see higher or lower rates of HIV? Right? So who says, positive association, right? In countries where there are more searches related to stigma, you would expect to see higher rates of HIV. Yeah, okay. And then who says like negative association that you'd expect to see in countries where there's more searches related to, relatively more searches related to stigma, you would expect to see lower rates of HIV? No one. Okay, so this crowd is right. There is a positive association, but I can tell you, okay, so I'm going to sort of out myself as someone who got it wrong. I did expect to see positive association, but I got the sort of the causal, my thinking in the causal direction was that I was thinking that if you have high rates of stigma, or if you have high rates of HIV, then that's a lot of people that are affected by this disease, and so you'd have like a sort of a better mental model of like how to stigmatize those people. And that was based off of my experience just being Black, because like when I was in Sydney, where there were no Black people, and like I felt like there was not that much racism that was directed at me, and I was like, oh, it's because you just haven't seen enough Black people, right? So that was sort of my thinking behind this. I was wrong. If you read a lot of health literature, am I wrong? Yeah, and so I was wrong in the causal direction. So if you read health literature, they were saying that, so you see there's been a lot of studies that have looked at, how rates of HIV and stigma are related to one another. And what they were sort of saying and conjecturing was that if you have high rates of stigma, they were seeing a lot of evidence that was leading to riskier behavior as a result of the stigma, and also people were getting tested less. So if something is very stigmatized, even if people know that they may have been exposed, they don't want to get like tested because then it's like sort of, I guess, official or whatever, right? And so there's lower rates of testing, and also there's just like a lot of cultural and maybe even physical barriers to getting tested. Like I know that when I was growing up in Ethiopia, there were like specific places that you could go to get tested, and if people saw you there, then they'll just assume that you had a reason to get tested, and that would lead to further stigma regardless of how you may have tested, right? So there are a lot of barriers around this. Also, people don't adhere to drugs that much. Like when I was growing up in Ethiopia, we also had these like sort of infomercials that were showing like a guy sitting at a cafe with his friends, and he'd like look at his clock a lot, right? And his friends are like, do you have somewhere to be? And he's like, oh no, I just have to go to the bathroom. He goes to the bathroom to take his drugs, right? Because he wants to take it at a specific time, but it's not something that you can just take in front of your friends, because then they would ask questions and then you'd get further stigmatized, right? And to me, it was so interesting. I read these papers, and I was like able to map into these experiences that I've had before. But at the same time, I was also seeing this association in the data that I had, right? That would have just been there regardless of what experiences I may have had or what other papers that I have read, right? And so this is just sort of like one connection here that we really only scratched the surface of, but that can be explored further. And another thing that we did was also we took all 100 topics, and we wanted to see whether any of these topics were sort of showing statistically significant association with HIV prevalence rate. And the stigma one was, I think, the only one that showed statistically significant correlation with HIV prevalence, and it had a correlation coefficient of about 0.5 or 0.47. So we think that there's a lot to explore here, but because we were doing this sort of observational study, we kind of did that and then just sort of moved on. But I'm excited to explore some of the further work that might show up here. And then we also promised that we were going to look at how people's information needs were being met online, right? So if you're searching for things related to HIV stigma or HIV natural cures or HIV pregnancy or whatever, are you getting like the same quality content, specifically as measured by health experts? So what we did was we took a sample of web pages that would be shown to users, and we gave these web pages to people who had graduate level training in medicine and public health, and we asked them to rate it based off of relevance, accuracy, and objectiveness. And what we found was that, perhaps not surprising, right? So if you had a rating of, we condensed it to just be one scale for the sake of presentation, but if you had a scale of 1 to 5, where 1 is showing bad relevance, bad accuracy, bad objectiveness, like serious issues with all three of these from a health expert perspective, we didn't expect to see that natural cures was going to be bad on this like 1 to 5 scale, but it was maybe a little worse than I expected. It was about 1.5. And we found that a lot of web pages that were returned to users related to searches related to stigma, searches related to breastfeeding, searches related to drugs were showing a rating of 4 or above, right? So they were, by and large, showing high relevance, high accuracy, high objectiveness, as measured by health experts. But this natural cures thing shows that there's potential for health misinformation potentially spreading as a result. And we wanted to understand exactly why, well, first of all, before we try to understand why this was happening, actually, what does that even look like? So if you go, you can actually do this on Bing or Google. So if you go on Bing and you put in one of these searches, let's say, does garlic cure HIV? The top page that you see is a web page that even I, as a non-health expert, could see had a lot of inaccurate information. And not only was it the top page, it was actually highlighted as the top page, right? So this is like one example of an experience that you might have if you were searching for these things. But what if you're searching for, say, antiretroviral therapy HIV? Then that looks totally different. Not only do you have this top page that was rated actually highly by a lot of the RAs who helped us, but also on the left-hand side you have the Wikipedia page highlighted, and it also says things like, what do you want to know about this condition? And it has all these different suggestions like, like pharmaceutical enhancers and table of antiretroviral drug interactions. And so these two experiences look very, very different, right? It's not like, it doesn't matter what you're searching for, you're getting sort of the same quality information or the same type of experience. This is very rich, and that is not as rich, right? And potentially also confirming or spreading misinformation. So what are the causes of this? What are some potential causes? Well, the first thing is that if the individual is typing in queries that are prone to misinformation, that's just one potential source. If someone is already saying, does garlic cure HIV, that's already kind of nudging the results that they might get in a specific direction as people who are just studying things from our computers separated from individuals. There wasn't that much that we could do. And then another source is the search engine itself, right? So the Bing search engine can take these search queries and map them to web pages. And what we found was that there was fewer. So like if you had typos, it would like alter the typos so that it can have better quality mapping that it could do. And it was doing far less of that for searches related to natural cures, right? So there was issues of bias with the search engine itself, and right now we're in conversation with the Bing search engine team to see what can be done there. But also, I mean, even beyond fixing this bias, you also have just this, right? These are very different experiences. So I don't know how amenable they would be to it, but that's one source of potential questions that we could be looking at there. And then the last thing is that we found that there were far fewer high authority pages that could even be mapped to questions related to natural cures. So if you were typing, does garlic cure HIV, and you wanted to get results only from the NIH or the CDC or UNH or whatever, there just weren't even enough pages. There were significant differences in the number of pages available, right? And all three of these are feeding into one another, and all three of these are a potential source of further exploration or interventions to try to mitigate this. And specifically with the NIH, I'm in conversation with folks from the ACD group that Steve was mentioning earlier to see whether this is something that we could try to fix, whether the NIH could have a webpage that says common misconceptions about HIV, right? And now you actually have something to map these searches to if you were interested. And so this is sort of wrapping up the search data presentation part of the paper, but zooming out more broadly, I am interested in using sort of applications of AI and the broader set of techniques that we have that we apply to a variety of contexts to improve access to opportunity for individuals. I'm doing a lot of work partially with the NIH, where we're both to try to build bridges between these communities, right? There's a lot of health experts that actually have access to a lot of data, have a lot of insights into every, whether you're thinking about maternal mortality rates and disparities that exist, whether you're thinking about sort of like data custodianship problems of like, what does it mean to make data accessible in a way that is usable and ethical. So all of these things are conversations that are really only just starting to be had, at least in this interface of AI and health. And so it's exciting to be part of this working group to try to like draft out a set of, we were told to call them findings, not recommendations, but they're recommendations that they can do what they want with. So that's one set of things that I'm doing, but more broadly also, as Steve was mentioning, I'm one of the co-founders of the Mechanism Design for Social Good group, and this group was started actually as a reading group. It was like an online reading group. There was, so it was me and Kira who started it, and we had about 12 to 15 people who were meeting online once every 2 weeks to read papers, to try to identify sort of public sector areas where techniques from mechanism design, algorithm design, modeling, these set of things that we really enjoy working with could be applied for, say, allocating low-income resources, or helping small-scale farms in Africa, or designing technology for low-resource job seekers, stuff like that, right? Where can we try to be more engaged and try to be of more help? But since then, the group has grown significantly, so now we have these sort of parallel working groups that are meeting, and they're very actively engaged with domain experts, and they're working towards research projects, right? So, or projects that would be harder to pursue, sort of where to do just like by yourself or just with other computer scientists or something. And there's 6 of them. Just to highlight one, so the Developing Nations Working Group is one that is exploring the interface of mechanism design for social good and ICTD, and also development economics, right? What are some questions there that we really haven't asked, where we could try to improve access to opportunity for folks living in resource-constrained regions? And it's led by Moses Namara and Francisco. So Moses is an HCI person, so you guys might know him. And then Francisco is an algorithmic game theory person, and the group is like, it's like a really lively group. I could go on for a while about it. I won't go into it. And we've also had an online colloquium series where Tewana gave the January colloquium series talk. So she was talking to us about what does it actually look like to design tech for good, and specifically for low resource job seekers, work that you guys know intimately, I'm guessing. So I'm preaching to the choir. But we've also had other folks, including Professor Al Roth is someone who won a Nobel Prize in part for the work that he did in market design for school choice and market design for kidney exchange. So he's sort of one of the seminal figures in this space, and he was kind enough to just call in on a random day and just share his work with us, as Tewana did, which we're very grateful for both their time. And we have a workshop series, and I'm so excited that I actually have time to tell you more about it. So we have a workshop series. The 3rd one is happening as part of the Economics and Computation Conference this summer. And we are very excited. The group has been growing significantly over the past 3 years that we've been doing it. And this year especially, we're thinking very critically about how to welcome people from very different communities. So, usually we would get submissions from like the theory crowders, and we'd get submissions from the algorithm design, mechanism design people, also theory operations research people. We're starting to get more engagement from like folks who are doing more AI type work, but not a lot of HCI people. So like that's something where we could definitely use more domain experts showing up and teaching us more of what you think about. And then also we have a track on empirical studies. So this would be economists, social scientists. We've had like presentations from like a keynote speaker from sociology last year, who was one of my favorite speakers that we've had so far. So we're trying to figure out ways to be more inclusive. And then also we have a problem pitches and demos track. And that's specifically for people, well, it could also be academics, but that's specifically for people who might not be academics, but have a lot of domain knowledge about wherever it is that they're working. It could be like a health expert in wherever they are, and they know exactly what kind of resource allocation problem could be really useful here, but there hasn't been like that much contribution from, say, the community people that we would have at MD first year. So that would be someone who can come in and say, I don't really do algorithm design or mechanism design, but I can tell you exactly about what set of problems we have here and where we could actually welcome some collaborations. So we've had interest from several NGOs, we've had interest from a couple municipalities, which I'm also very excited about, and we're trying to figure out ways to make the conference as inclusive and accessible to people of all backgrounds who might be interested in this mission. And we also have product demonstrations that people can participate in. And this is my thank you slide. These are my collaborators at the top for the paper that I presented to you, and that's my advisor, or mine and Daniel's advisor, and Kara Goldner and Irene Moe, who've been my co-partners in crime and anti-forestry for the past 3 years. Thank you. This is the broader set of people who do anti-forestry, leadership stuff. I won't name all of them one at a time, but this is an awesome collection of people that I've had the pleasure of working with. Any thoughts, questions, concerns? Yes?
Yeah, really great talk. I loved it. I was wondering about the notion of using Bing search engine as the proxy for studying this kind of behavior. So Bing users have a different kind of demographic, and it's only like 1 to 2% from the estimates I've seen in terms of market share. And they often are older and less tech savvy. So I'm wondering how that might affect the interpretation of your results if there's a certain demographic skew who may be more prone to looking at certain kind of queries, the home fulcrum as you talked about, whether that's true of the general population as well, or whether that may be shifted to the demographic of who's using data. I was wondering if you could give me thoughts on that.
Yeah, no, absolutely. So that is a really good question, and that was a question that I wanted to have. Well, so first of all, regardless of whatever we try to do to mitigate the limitations, there's always going to be limitations to using this kind of data. But this was an especially difficult case, right? Because this isn't just say users in the US. We have some understanding of who exactly uses Bing in the US. We don't really have that in Africa. There are a lot of complicating factors. So a lot of people, at least anecdotally, we know that a lot of people just use whatever default search engine comes with your computer, and a lot of Macs are not, you would not see a Mac in Ethiopia. Maybe now you would, I've left a while back, but you really wouldn't. It's not as popular, right? And so a lot of the Microsoft products that you would use come with Bing, and people just use whatever it comes with, right? When I was leaving, people were still using Yahoo. It's we would not use Yahoo in the US, right? So it's a different demographic, and I don't even want to lump all African nations as one. We don't even know what the variance is between African nations. And what I tried to do was I tried to learn what folks in information retrieval, for instance, what work they've done to try to understand what we know and what we don't know. And I can say, I think fairly, that there's just really isn't that much work in that space, which goes back to the question of why are we not doing almost any work related to a fifth of the world's population. Africa is 1.2 billion people, and yet we don't know what percentage of them actually would use Bing versus say Google or whatever, right? And also this was internally also an issue. I had many conversations with Bing where I was hey, could we try to do interventions in this way? Let's say can we use ads? And they're oh, we don't actually have ads in Africa. And I'm well, that's how you generate revenue. Why don't you? And they're they're just not a big enough market share of our entire market share, and so we just haven't turned it on, right? And so it really is. I think it made it much more difficult to do any work here, right? And actually, for a while, I was doing stuff in parallel where I would be if I was asking the same questions but looking at populations in the U.S., how much more would I be able to do? And the answer was a lot more, right? So that's one issue, and I think that's just pointing at a gap that exists in the literature that I didn't feel I was best positioned to study, but I think someone really should study. And but we did do some, we did do some just trying to see we looked at the age distribution of reported ages. We truncated it below 18 we didn't want to look at, and then also above a certain age, I think it was maybe 58 or something, it was way too sparse, and so we didn't want to look at it. And so we looked at how does that correlate with just the age distribution that we know of African nations, and it correlated heavily, and so that was sort of added to the appendix, which we're still in the process of putting together before the camera ready tomorrow. Yeah, okay, so I have my work cut out for me tonight. But yeah, so we're looking at that, but I don't have any satisfactory answers, but I don't think I was going to ever have them because there's just a lot of work that has to be done there.
It's a
Yeah.
hard question, so I was curious what you thought.
Yeah. Sorry about the mild monologue. Yeah.
Thanks for your talk. I have a related follow-on question to David. So, with a lot of these kinds of analyses, and the problem is obviously not just age, right? It's, in this case, it's also lots of demographic situation, context. In a lot of these, in a lot of African countries, there is a relatively wealthy, educated upper class that is in fact the one who's doing all these searches.
Yeah.
And then everybody else, who are really the ones who have a lot of health problems, are very unlikely to be doing searches for similar things.
Yeah.
But, I mean, I think you did you did a good job of picking out the kind of interesting things you can discover that are still meaningful.
Yeah.
And in a funny way, it kind of reminds me of the value of like qualitative work as opposed to quantitative work, right? In theory, quantitative work gets you more internal validity as well as external validity in some cases. But in this case, you're using quantitative methods to get at insights that are, to some extent have the character of like qualitative insights.
Yeah.
Do you have a way of thinking about, how, what kind of interesting insights you can get from this methodology, knowing that you're never going to have the representative sample that you would want for a more quantitative approach?
Yeah. So like me, myself, or just one in general?
Yeah, just, have you thought about like what are the kinds of insights you can gain from this that will actually contribute, good research insights, as opposed to, there are some things that I think, like you said, this methodology is flawed in some ways that are not easy to correct.
Yeah.
And probably will never be able to correct it. So,
Right.
what's the class of insights that you think this methodology can provide?
Yeah, that's such an awesome question. Yeah, so we've thought about this. I don't know if I've gone as far as like trying to characterize the tools or even a partial set of things that I think would be interesting, but one class of things that I knew I would be comfortable trying to do was supplementing domain experts that already exist, right? So we knew that health experts in this space were like, we don't have enough information, say, related to like what beliefs and natural cures there exist, right? And so there, really, any sort of contribution that you could have there that can be backed up with something is useful. At no point were we like, we're going to give you the exhaustive list of things that are out there, right? Because, like you mentioned, there are a lot of people who are not online, and maybe the beliefs that they have about natural cures are very different from ones that you would see online, but that doesn't mean that the ones that we see online don't exist. They do exist. That's why they were part of our data. So I think that kind of stuff, like I think it's both like a limitation but also an opportunity, right? When you're in this space that just like, there just haven't been a lot of quantitative like analyses that have been done. If you have like rich data sources, you could try to like even say like the first pass of things that you'd be able to say could be potentially useful, but you have to like work with a domain expert and say like, what can I say that's useful, right? Because like, when we first started this project, it was more computer sciencey people, and we also had like our own computer sciencey knee-jerk way of trying to do things, which was, can we predict like HIV prevalence rate? But we sat with it for like a minute, and we were like, oh, there's like many different reasons why that's not a helpful question to try to answer, and so we moved away from that. So I guess that's one class that I would say, just go to a domain expert and say like, I have this rich data source, what can I extract from it that would be useful to you? But yeah, it's something that I'm still thinking about, and I think there's a lot that I can learn from just like other communities in CS that have been thinking about this in different contexts, like ICTD, for instance. Yeah.
I was wondering if you feel comfortable to tell us a little bit more about some of the questions that you chose not to ask for ethical reasons.
No, absolutely.
I understand
No. I'm absolutely happy to talk about it. So one of the big ones that was like a definitive like decision that we had to make was looking at how people searches evolve over time, right? So like if you were asking things like, does garlic cure HIV? What do you then ask next, right? And one of the things that I tried to do with this paper, I don't know, maybe everyone else does it too, but one thing that I tried to do was before like automating whatever it is that we're trying to extract, I first tried to like look through the data like manually to try to get a sense of what we look at, right? So if we were looking at like what are people's health information needs, I first extracted just like a random sample and just sat there and like read through all of them, right? Just to try to get a sense of what I might be able to expect to see. I felt like that might help me ask better questions. So in this sort of like how do people's searches evolve over time, I did start to do that. I did look at like just like a sequence of searches that we knew were coming from the same anonymous ID. And it was very difficult for me to go through that process, right? Because sometimes it was like completely, you could tell that someone was like writing an essay about HIV, right? Like the set of questions that they were asking were like, oh, you're like writing about socioeconomic disparities and HIV, right? But then other times it was very clearly someone who was like in a very difficult situation. They had like low CD4 count, they're pregnant, they got tested too late, they whatever, and then at some point they were like, it was like the last time that they did anything was like in April, and you're like, did they pass away between April and when I'm looking at the data now? And like when I was starting to go through that, to me that was again like a question about like what you're comfortable with and just like mental health, and so I decided that like wasn't comfortable for me, but I also felt like probably the reason why I wasn't so comfortable was because now I have this much richer model of like what an individual is by looking at their sequence of searches. And so, I don't know, it was sort of like, are we trying to like reverse engineer like individuals from like their sequence of searches? I don't know. I'm sure other researchers may have fallen in a different, on a different side than I have, but to me I was just like, I'm not comfortable doing this, and that was that. So that's one example. Yes?
You may have already said this. Did you solely look at English language searches?
Good question. Yeah, so we did. Well, I mean, because of the way that we calculated it, it ended up being mostly English languages, but I was curious how much of an issue that was going to be. So we looked at a set of just like random searches from like 1,000 random searches like in any language, and we looked through them manually to just see which ones were in English and which ones weren't. And the vast majority were in English, and then almost all of the non-English searches were coming from like 3 countries basically. Like they were in French, Portuguese, and Arabic, and they were coming from like Senegal, Egypt, and one other country or something like this. Like it's in the appendix, but basically, yeah, we did end up like not getting a lot of data from like less than a handful of countries because of the way that we were filtering it. But I think this is actually like an interesting question that NLP people could do, right? Because we know that as more people are coming online and as there are more web pages available in different countries, people might end up using different languages to search things. Right now, if you like type any, like I speak a little bit French, and I type things in French, and I'm like, this is not really usable for me, right? Partially because I don't actually really speak French, but like it's not, but it's the experiences are not the same. So I think it nudges people to use English, even if that's not language that they would use normally. But what happens in however long it might take for people to for like search engines to become more usable in other languages, maybe even local languages, right? I think that's like a challenging NLP question that people have to think more about. Yeah.
So you talked a little bit about the role of the search engine in this kind of cycle of misinformation. So wondering if you looked in particular about like recommendations and like whether these sort of were sometimes driving some of these sort of fake remedies, like I'm looking for garlic because I'm cooking, but then I discovered that it may also be a cure for HIV.
Yeah, I don't know if we had, that's a very good question. I don't know if we had that information, and I don't also remember specifically looking for it, right? I'm just thinking it like going back to we didn't have ads. Like maybe I wasn't able to extract that. I don't know, but that's a very good question. Like what percentage of them were driven by auto recommendations versus like you were just doing anything? Yeah, very good question. Yeah, I don't know.
Thank you for your talk. I really enjoyed it. So this is, I think, building off of your response to Kintaro's question. You said you would, go to the experts and talk to them about what questions that they have.
Yeah.
Have you done that? And
Yeah.
because now you're I guess on the board of directors for the NIH.
No, we are the
advisory
people.
board.
We are the people to talk to the advisory committee.
The
So
advisory
we're
committee.
one layer down, but it's still pretty.
And so what kinds of questions have you gotten
Yeah, so, maybe the last speech would have been better. So Peter Small, so you can't really read it, so Peter Small, who's one of the co-authors on this paper, he was at the Gates Foundation in the TV delivery program for like 20 years or something, right? So he's someone who has thought a lot about infectious diseases in developing nations and a lot of southern part of the continent in Africa. So he was someone who drove a lot of the questions that we ended up asking because of his experience there. And then what happened was, part way into the paper also, we ended up just getting connected to a lot of people who are, so we talked to a couple of doctors in Ethiopia, we talked to a couple people in the Ministry of Health in Ethiopia and Ghana, and the Ministry of Health and Hygiene in Mali. So we've been having a lot of these conversations that didn't really make their way into the paper, but we're taking some of the insights that are specific to that country and trying to pass that on. So those conversations are still ongoing, and they may or may not end up being a research paper, but it's something that's we've done a lot of the work anyway, so we can try to just see whether we can extend the use of the insights that we have here beyond this. So so those are two things that we've done, I guess, two classic things that we've done.
So I've seen these tools where I guess we can go in and ask questions about the data.
Yeah.
Is this something that you've considered, with this project?
What kinds of questions?
Well, this was these were more like basketball stats.
Yeah, okay.
So if this team
Similar.
wanted, right, but I just wonder if it's possible. It's more like data exploration for experts, I guess, so that they can begin to.
So making the
explore
data
queries.
accessible to them.
Yeah, is that
Yeah.